Okay, hi Michael, it's Dr. Buford. We're just getting started on your right shoulder. We're looking in from the back to the front. We examined your shoulder before we started. It was very unstable. It would dislocate quite easily to the front, and there was also some posterior and inferior instability. All of that goes along with our diagnosis of some multidirectional instability. We're looking here to the left of the gray cannula. That's the biceps tendon. I know you've seen one of these videos before because you have a matching set. But this is the same biceps tendon that we saw on the left shoulder. As we look down, this is the biceps insertion. On the MRI scan, sometimes these little areas show up as a little bit abnormal, but when we look under arthroscopy, we can probe it and tug on it to make the diagnosis, and we can see that this is truly not the type of labral injury that needs any repair, at least not in my opinion. I think that'll be fine once we deal with the instability. So the rotator cuff is up here. Rotator cuff there looks just great. No signs of any significant tearing there. It's inserting into the humeral head like it's supposed to. As we look down the back of the shoulder, we can see posterior capsule here. The insertion into the humeral head looks fine. We get a little bit of fraying in the posterior labrum, but the most remarkable thing is the way that there's so much extra space back here. Look, as we pull back, we can see that glenoid looks like it's just an island. And that's one of the hallmarks of somebody with very loose capsular tissue. And we're going to be addressing that today. You can see some tearing here. I think it's probably coming off of our portal, or maybe a little bit off the posterior aspect of the cuff, but not a significant tear. And then as you look down the front, you can see some fraying of the labrum, but no significant detachment. So we're going to get to work. We're going to put the camera in the front next. Okay, so now we're looking at the posterior aspect of the joint. We've got this instrument called the rasp coming in, and we're just going to use this to gently roughen up the posterior capsule. We're going to try and create a thickening in this posterior band of the IGL, which is basically right at the tip of this rasp. Right through here, we're going to be placing our sutures. We're going to place an anchor into the glenoid as well for added security here. Flushing out the joint. Alright, so after we rasp this a little bit, again, we're not trying to create any bleeding or remove anything, just to make it more like a piece of Velcro here. So here's our spinal needle. This allows us to check our angle of insertion. That looks pretty good. Okay, so here's our guide in position. We're going to go ahead and use a drill. And then after this, we'll take the anchor. Okay, so there's the drill coming down. And now into that hole we're going to place a suture anchor. Once we have that anchor seated, we will unload the inserter. We'll seat the anchor while pulling back on it, and that looks very solid. So now we're going to take one of these sutures and pass it through the capsule back here. We'll show you that in a minute. Here's our suture hook. We're going to start by placing the tip where we'd like to finish. Then we're going to rotate back and go into the capsule right about there. Go ahead and take that bite. I'll show you some more in just a minute. We're getting ready to make our second pass. We're doing what we call a mattress type of stitch, and this is a particular type of mattress stitch that we call a figure 8 because it gives us a little tighter repair. Okay, so there's another bite through the capsule, and now we're going to come under. figure 8 stitch, and now we're going to tie a knot. Our post is always on the capsule side here. So we're just checking that. Can you see? Can you angle this towards me a little bit? Thanks. Towards Melissa. Great. Okay. So we're going to push in here. That's our post. We're going to take a mosquito here, and now we're going to tie a non-sliding knot. We'll get that done and show you some more in a minute. We tied the knot. You can see how much tighter that is. That makes that posterior band of the IGL much tighter, allows us to tighten the inferior portion of the joint, and most importantly, to center the humeral head over the glenoid. So we're going to go ahead and stop there. I don't think we need to do anything else back here. I just wanted to give you an idea of what that single mattress stitch accomplishes there for us. Now we're going to have a look down the front and get to work here because we don't really see a good anterior band of the inferior glenohumeral ligament either. Okay. Okay, so we're placing another suture anchor. This one's going in the front of the shoulder. Here's the anchor in. I'm pulling very hard on both sutures. It's seated and it's very solid. We're going to go ahead and reach in from the back and take out one of the sutures here. Okay, and now we're ready to use the suture hook to put a grasper in the back. We're ready to use one of our suture hooks to make a stitch in the inferior capsule there. We're done in the front of the shoulder. We only put in one anchor. It's a mattress stitch, so we covered a fair amount of real estate. And we're all the way up to the subscapularis tendon, so I don't think we need to put an anchor at the rotator interval right here where my shaver is. You can see how much tighter it is. I can't see down the front anymore. And as we look towards the back, we can't really see down the back anymore either. So I'm happy with that in terms of it being a balanced repair. So I'm trying to see if I can get these bubbles out so I can see a little better. There we go. So as we look at the rotator cuff back here, we can see there's no significant injury back here. I'm going to slowly back out this cannula. And I think that's going to be it. I think we're going to finish up here and get you back to the recovery room shortly. Okay? Happy with the way that looks. Good luck to you now. Bye-bye.